Good evening, friends. I'll be giving a brief overview on this antibiotic stewardship and what are the barriers that we may be having in incorporating this. So, this is a question I'm sure is asked in DNB, and this we are doing it in the context setting for the regard WAP trial that has come out in Lancet, which will be discussed after this talk. We'll just try to cover the basic tenets of what governs the good antibiotic stewardship. And it's imperative that every intensive care trainee knows about the nuances of this stewardship program. So let's look into the background. So what we need to understand is terribly important that we use optimal antibiotics or optimal type of antibiotics, and this is important in the face of increasing resistance patterns that we are witnessing in our country on and in globally as well. And there are no new antibiotics in the pipeline. So this is the background we have. And it is shown that 30 to 60% of the antibiotics that we use in ICU, 30 to 60% is unnecessary, and it may be inappropriate because we may be using antibiotics not necessarily which may be covering the bugs that we may be having there. And the suboptimal usage, the dose may be suboptimal, duration may be suboptimal, or the frequency may be suboptimal, or the way it is administered may be suboptimal. And this inappropriate usage of antibiotic is shown with increased prescription. There may be increased prescription of these drugs, or there can be misprescription. So where there is erroneous prescriptions, all this leads to inappropriateness of the antibiotic. And the epidemiological data from good epidemiological studies has shown with the rise of usage of antibiotics or indiscriminate increase in the usage of antibiotics is directly proportional to the emergence and dissemination of resistant organisms. So this is the sort of background we have, which means all of us are party to this because in ICU is a place where we tend to overuse antibiotics, and every time we use an antibiotic, there is a direct correlation to the emergence and dissemination of resistant bugs, which we ourselves have to tackle in ICU. So when we look at some of the studies for de-escalation, why we speak about stewardship? Because de-escalation forms an important aspect of antibiotic stewardship. When you look at this good trial which came, de-escalation versus continuation of empiric antimicrobial in severe sepsis. This was a French trial done in 9 ICUs in France, multicentric RCTs. There are 116 patients in patients with septic shock or severe sepsis where 59 they had effective de-escalation. In 57 they did not de-escalate. And if you see the time, the duration for de-escalation in the group where antibiotics were displayed was 3.2 days. So they looked at 90-day mortality, there was no difference, which means to say, many often you would see that the patient may have come with severe sepsis, you have started an antibiotic, and you would say, why should I de-escalate? Patient has possibly responded because of this antibiotic choice that I put in, and you would continue. But in fact, it is shown that de-escalation did not have an effect on mortality, and ICU length of stay also, there was no difference. And in this particular patient, in severe sepsis, why this is important is they looked at the blood culture positivity happened only in 34%. So only 30 to 40% of the blood cultures we sent in severe sepsis come positive, which means the rest of 60% of the patients we may have to be treating empirically. And that's where the choice of de-escalation becomes difficult. So when we talk about sepsis, we have to reflect on the definition, which is a life-threatening organ dysfunction due to dysregulated host response to infection. So if you apply this definition and use antibiotics, obviously when you see this definition, life-threatening organ dysfunction due to dysregulated host response, so you would want to throw in an antibiotic, right? But this life-threatening organ dysfunction can be viral, isn't it? We get dengue with a multi-organ dysfunction due to dysregulated host response. But would we use antibiotics there? Then we have a SIRS patient, SIRS like pancreatitis with SIRS, burns with SIRS. Even they have dysregulated host response with life-threatening organ dysfunction. Would we use antibiotics there? And then you have non-infectious causes of fever. It can be a drug-associated fever leading to problems or transfusion-related sort of a organ dysfunction. Or it can be non-infectious like intracranial bleeds. Very often you would see patients having a smoldering low-grade fever and we throw antibiotics in these cases. Or you have a increasing number of oncology cases where multi-organ dysfunction can maybe just the progression of underlying malignancy or underlying disease, and we throw antibiotics. So these are some of the typical clinical situations where we use antibiotics because of applying this definition. There is life-threatening organ dysfunction due to dysregulated, and in any of these patients, only 40% may have culture positivity and using antibiotics. So 60% of the time we may have cases like this. It may be viral, it may be SARS, or it may be other non-infectious causes or progression of underlying. And we end up using antibiotics. And this is where the problem is, and this tantamounts to our medical malpractice. So 60% of the cases would belong to one of these situations, and we end up using antibiotics, which means we're all party to some sort of a malpractice by using inappropriate antibiotics. So when you look at de-escalation of empirical in severe, this was another study. So the previous study, the French study showed non-inferiority, but if you look at this study, which is a study which came from the Spain, where they showed there was a protective effect or mortality benefit in the group where antibiotic de-escalation happened. So in this group, they had 628 patients, 219 in the de-escalation group, 403 where they did not de-escalate. These are patients with severe sepsis and septic shock. And if you look the odds of survival, so patients in the de-escalation group had a survival benefit. If you look at the confidence interval, it was significant. And 90-day mortality had a survival benefit in the group where antibiotics were de-escalated as opposed to the group where it was not de-escalated. So, and even in this particular study from the Spain, the blood culture positivity was around 38%. So overall, if you see in sepsis and septic shock, the blood culture positivity we can expect only in 30 to 40%. So that is something we need to keep in mind. And this is a reference study which tells you that de-escalation saved more lives. And this study was published in 2013 from the Spain group. So what are the ways, what are the means and ways that we can adopt to de-escalate? So why we give indiscriminate antibiotics? Because the signs and symptoms of infection are very similar to non-infectious causes, and we end up using antibiotics for this. As I said, 60%. It can be viral, it can be SARS, progression of underlying disease. All this we end up using antibiotics. So what is it that we can utilize to stop antibiotics in these situations? We can use procalcitonin. That's where we need to rely on. So procalcitonin is a adjunctive help that you could take along with the clinical situation to de-escalate antibiotics. And for that, is there a good evidence? Yes, there is a good evidence. This is a pro rata trial which came again from the French group, where in this particular study, where they had 50% of the patients with community-acquired infections, 50% with hospital-acquired infections, and 67% of the patients were mechanically ventilated, done across 621 ICU. And when they used procalcitonin to de-escalate or stop antibiotics, antibiotic-free days was higher, 14.3 versus 11, which means they could curtail the use of antibiotics with the use of procalcitonin, and the outcomes were better. And this study came in 2010. After this, there was a big meta-analysis that came from the Switzerland group, 2018 by Wirs et al. If you see very carefully at this meta-analysis, they took 11 randomized controlled trials with 2,252 patients, and where procalcitonin was used to de-escalate or stop antibiotics, if you see, the mortality was lesser compared to the control group, and that was statistically significant. And the duration of antibiotic also significantly less. So these are two reference studies where we have, which shows by using procalcitonin to de-escalate or stop antibiotics, in fact, you can influence better outcomes. And this meta-analysis showed even there was a mortality benefit. In fact, after this, there was a recent trial from the Greece also which showed mortality benefit. So it is very important to appreciate that indiscriminate usage of antibiotics in multi-organ dysfunction where there is no infection can worsen outcome rather than save lives is what is reflected from the study from the Spain and from these procalcitonin studies. And this is another important sort of a study which came in Lancet Infectious Disease by Hanjic et al., where they showed in patients who are hemodynamically stable, delayed initiation of antibiotics did not worsen mortality, but on the contrary, where in this particular study antibiotics was used after the culture, but this is in hemodynamically stable. Using antibiotics after the culture reports come, reduce mortality, increase appropriate antibiotic usage, and reduce the duration of antibiotics. So this is in possibly non-ICU settings where patients are hemodynamically stable, where they have said you could possibly wait for the cultures and then take a call whether you would want to start antibiotics and that has shown to reduce mortality also compared to the ones where you have started empirically. So these are some of the references you have. By not de-escalating, so there is 60% likely error of judgment, because as I said, 60%, only 40% are culture positive, and 60% we end up using antibiotics for possibly non-infectious causes. And this may increase the cost to the patient, increase in the resistance patterns, and increase the mortality. And this leads to sacrilege of 3Ds, which I say 3Ds are the sacrosanct for antimicrobial stewardship, where we talk about right dose, right duration, and de-escalation. By not de-escalating, you are sacrificing 1D. So inappropriate antibiotic usage, as I already mentioned, is done in 30 to 60% of the patient and leads to emergence and dissemination of resistant organisms. And these are the situations where we continue to use antibiotics. And there are two RCTs which shows beneficial effects of de-escalation, and meta-analysis shows inferior, non-inferior. And there are two large procalcitonin studies. One was a pro-rata trial. The other one was a meta-analysis by Wills et al. From Swiss group, where it shows use of procalcitonin uh, to de-escalate helps to save more lives. So this is the sort of a background we have as to why we need to adopt antimicrobial stewardship. Now we'll jump very quickly into the salient aspects of antimicrobial stewardship and what are the barriers that we have. So our primary goal is to optimize antibiotic treatment to influence best clinical outcomes. And most importantly, in addition to improving outcomes, we are duty bound to reduce the emergence of drug resistance. And our secondary target is obviously to reduce the cost. We do not want to indiscriminately use antibiotics and increase the cost, reduce the cost to the patients without affecting the quality of care to the patients. And the tools for success of antimicrobial stewardship is the teamwork, and it is important to give a feedback, sort of have a feedback process for the clinicians, whether they're using the right appropriate antibiotics, and and calibrate your treatment and titrate the treatment with a focused, targeted sort of a therapy are the key tenets of or the key tenets for the success of antimicrobial stewardship. And when we talk about antibiotic stewardship, AMS is antimicrobial stewardship. It is not limited to only ICU. It is limited to outpatients. It is limited to inpatients, and it is even applies to long-term care centers. And we need to incorporate processes at the OPD, inpatient, all the processes in place to make this happen. And it is a core function of the doctors and the nurses put together, who should understand the value of incorporating this antimicrobial stewardship. And one has to utilize the experience and expertise of all the lab people, infectious disease person, infection control nurse, and the IT team. So why we are mentioning is the antimicrobial stewardship or the infection control is not the duty of only an intensivist or a doctor. It is a teamwork. It involves the nursing staff, it involves the lab technicians, it involves the pharmacist, it involves the ID people, including IT, because IT is very much instrumental in getting the reports in a timely way, relate in a timely way to the clinicians to act upon it. So all this becomes integral to the success of antimicrobial stewardship. And what are the difficulties and challenges in implementing antibiotic? If there is lack of trained clinicians, and if there is a lack of trained pharmacists, and if they are not participating in antimicrobial stewardship due to various reasons, they may cite lack of time, and very often that is sold, or there is no incentivization for them to follow the antimicrobial stewardship, or there may be conflicts between the microbiology, the clinicians, ID teams, pharmacists, so on and so forth, or there can be divergences in their understanding of antimicrobial stewardship. All this leads to failure to incorporate antimicrobial stewardships. So no incentivization or no financial gains by adopting this is possibly one of the reasons that is cited, and lack of good IT resource or IT involvement in this stewardship also is an impediment for incorporating effective antimicrobial stewardship. And it is also shown there is lack of consistency in what is expected out of antimicrobial stewardship and what the clinician follows or what the ID physicians follow. There can be dichotomy or there can be divergences in what is expected and what is being followed. Most importantly, failure of application of knowledge of incorporating antimicrobial stewardship has shown to emerging antibiotic resistance. So this is very important. They are aware that all the clinicians, I'm sure every listener in intensive care knows how important is antimicrobial stewardship, but they end up using indiscriminate usage of antibiotics, and that is lack of application of knowledge, not clearly understanding, that is leading to the emergence of antimicrobial resistance. Is something that is happening to all of us who are doing this. Even though I am talking here, we may be many a times using antibiotics despite lack of evidence that there may be infection, and all these have a role to play in increasing antibiotic resistance. And antimicrobial stewardship somehow is not looked at as a priority by the clinicians or by the organizations. And there's loss of autonomy, which means there's no sort of a um, autonomous role given to anyone to incorporate this or implement this as a regimental aspect in any of the organizations. And the behavioral pattern, all these are some of the impediments in incorporating antimicrobial stewardship. And the dilemmas that prevail is there are no qualified infection control nurse or ID specialists who are the sort of a torchbearers of implementing this antimicrobial stewardship in the organization. And there is reduced number of trained, qualified ID specialists or ID nurses or pharmacists, and lack of training. So all these are found to be barriers or impediments. And possible delays in appropriate therapy is there. This we see it very often. So there may be delay in communicating the reports of culture reports to the clinical team. That happens within, even sometimes in our hospital, we are aggressively following with microbiology. So there has to be communication channels which are perseverant and resilient with the microbiology team, so that timely capture of the microbiological reports happen, and there is no lag time in initiating appropriate therapies. So if there is a delay in the relaying of the reports, then there is a increased time that takes to initiate appropriate antibiotic usage. And many a times empiric antibiotics may be inappropriate because of the lack of antibiogram that is conveyed to the clinical teams. This is also very important. And there is a sort of a decision making fallacies that prevail, which also increases the time for initiating appropriate antibiotics. And these are all some of the impediments that remain in incorporating good antibiotic stewardship program. And the key, the operationalizing of certain processes to streamline these processes has to be put in place and needs to be monitored. And antimicrobial resistance is a quality and safety issue. This is something that needs to be conveyed to all the treating teams, because their indiscriminate usage of antibiotics leads to emergence of antimicrobial resistance, and which can lead to the breach in the quality and safety issue. And many a times staff may not want to assume added responsibility without adequate compensation. So when there is no incentivization for practicing good antimicrobial stewardship, very often staff loses enthusiasm in incorporating the principles of antimicrobial stewardship, and hospital administration may not pay for infection control teams or antibiotic management without guaranteed pharmacy savings. So these are all some of the other issues that govern non-implementation of effective antimicrobial stewardship within the hospital. And many a times the clinicians may think by regimentally following antimicrobial stewardship that they could get into conflict with other teams that may be involved in caring for the patients, and that may lead to loss of income. So all this I'm sure we're all facing in day-to-day sort of a practice. And as many of would be aware, the appropriate cultures may not be sent prior to commencement of antibiotic therapy, and there may be poor adherence to the antibiotic guidelines and protocols within the hospital. So adherence to protocols also is something that can be fallacious many a times. And poor working relationships between the intensivist, nurses, pharmacist, and the microbiology also leads to impediment or barriers in adopting good antimicrobial stewardship. And failure of engagement of other treating teams like surgeons or other treating specialities into the whole concept of understanding the antimicrobial stewardship principles and working as a team also is sort of a limiting factor for effective antimicrobial stewardship. So they have done studies, and if you look at this sort of a survey that came from the US, only 26% of the hospital uh, showed that antibiotic stewardship program was well accepted. So the significant chunk of the hospitals did not have good antimicrobial stewardship program. And the reasons were all this. So there was personnel shortage in 55%, financial consideration even in US at 36%, and higher priority clinical initiatives was looked at as 34%, and there was opposition in 20. So these are some of the barriers that was shown in a survey done in US. And this was another sort of a study where they showed only 53% of the clinicians responded to this antibiotic stewardship survey, and they showed that anti-stewardship program was implemented only in 50% and 30% were in planning stages. 20% of them had no plan, and this had an enormous bearing on influencing the Senate bill to be passed to incorporate antibiotic stewardship program as an important aspect in US. So, which means the barriers are prevailing across the globe, and most of the time, the barriers that are cited is the funding, the staffing constraints, and behavioral issue, and no administrative support. So this is very innate to even our Indian subcontinent, where all these problems do prevail. So how do we circumvent this? So we have a lot of impediments. So we saw there are so many impediments that are there to incorporate antibiotic stewardship. So because there are so many impediments, they came out with this sort of philosophy of low-hanging fruit of antimicrobial stewardship, which means try to reach out, go for certain achievable things rather than looking at all those aspects. Because when you look at all broad-based aspects, it appears very Herculean or very formidable for us to attain those goals. So they have now conceived the whole strategy of going for a low hanging. What that means is try to look at the targets which are easily attainable at low cost. So that's the whole concept of low hanging fruit. So what are the common strategies that we could adopt to make this antimicrobial stewardship successful in the light of all the impediments that we have? So the common strategies that you can adopt is try to wean to the less narrow spectrum antibiotics and try to de-escalate to the oral formulation and adopt these three Ds. So right dose to be incorporated, which is not difficult, which is low hanging, and right duration, because the regard WAP which we'll be talking is also trial to address whether we can curtail the duration of usage of antibiotics. In this day and age, 7 days is more than enough for most infections, and there are very limited conditions where one should exceed more than 7 days. Now the trials that are speaking is even curtailing it to even 5 days. So the regard WAP will be discussing that. And the third most important is de-escalating or de-escalation of antibiotics. When you're absolutely sure there is no infection, stop the antibiotics or de-escalate to narrow spectrum antibiotics. And have and follow specific treatment recommendations and protocols that are elucidated. That's a low hanging fruit. And you can have a pharmacy restriction where if you are starting a broad spectrum antibiotic, you can give it for up to 3 doses. After that, continuation of that broad spectrum has to be justified with your culture sensitivity, which we have adopted in our hospital. We have antibiotic restriction policy where a broad spectrum is given for 2 to 3 days. After that, one has to substantiate with the culture sensitivity and justify whether your continuation of this broad spectrum is justified. So those are some of the low-hanging fruits that we can adopt to make antimicrobial stewardship successful. And there are certain metrics for antimicrobial stewardships, which can be divided into four broad categories. One is to audit your clinical outcomes, look at the mortality by adopting this AMS, whether you have had any influence on mortality, length of stay, and whether your rate of nosocomial infection and readmissions has been curtailed. And the second broad category of metric is to audit average consumption of antibiotics and the average cost after incorporating antimicrobial stewardship, whether there has been change in the average consumption or average cost, and look at the drug resistant index. And the third dimension is looking at the outcomes, whether there was an appropriate audit, appropriate, whether there was appropriate usage, whether appropriate doses were used, and whether the duration of antibiotic used was right, and whether de-escalation was done. So this is a process outcome metrics. And the fourth one is to look at the resistance, whether incorporation of antibiotic stewardship program has had an influence on curtailing the resistance, whether there has been a percentage change or reduction of ESBL emergence, or reduction of MRSA, or reduction of drug resistant index. So these are some of the metrics one should be doing, which means it's a team effort. There should be sort of a administrative support for someone to do audit of all this, and to see whether adoption of antimicrobial stewardship program has had influence on these metrics. So summary, so autonomy has to be given to the infection control teams to adopt antimicrobial stewardship in a regimental way and in a perseverant way. And one needs to bear in mind that all the knowledge that is gained has to be applied to curtail antimicrobial resistance. And one has to keep in mind the balance in achieving good clinical outcomes. At the same time, be sensitive on the ecological perspective in curtailing and mitigating the emergence of antimicrobial resistance. And having a antibiotic restriction policy is difficult, is onerous, but it has shown to lead to curtailing the use of indiscriminate antibiotics, and incorporate some process in the hospital to make this antimicrobial stewardship happen. And what the key is to have sustained efforts, and and it is a teamwork. One has to involve the ID physicians, pharmacists, and so on and so forth. And effort has to be consistent. That is the key thing. The successful antimicrobial stewardship program needs innovative sort of ideas from the teams that are involved, and needs a good sort of a hospital management which backs this antimicrobial stewardship program, and it's a teamwork. So every ounce counts. So one has to think big. So start small, go for the low hanging one, and then think big to make things happen. So that's about the overview of antimicrobial stewardship. So I request all our listeners to attend to our signature program, JICS Global Intensive Care, that's happening in Bangalore from 17th to 20th. 17th to 18th is the workshop, and 18th to 20th is the conference. So request all our listeners to submit their valuable work to Journal of Acute Care. And you can visit my website, www.drpradeeprangappa.com, to rehear. Thank you. Thank you, one and all.